All right, everyone. So we have a pretty hefty PowerPoint with this module, only one lecture for this module. So that is the good news. But some of the more tricky news or a little bit more upsetting news is that there is a lot of new stuff that is involved with this lecture that we haven't really talked about, and a lot of this is very abstract. We're not really scanning a lot of these structures, we're not really evaluating them, but we do have to know about their anatomic position, their makeup, how they relate to everything else, so that when we do scan specific abdominal organs, we know what these supporting structures are, where they're located, and if we happen to see pathology, what we would do in those instances. So we're going to be talking about the abdominal contents. We're going to talk about the abdominal wall, the different sections of our abdominal cavity, what some of these structures are called. We're then going to move into our vasculature. So we're going to be talking about our great vessels. This means we're talking about our aorta and our IVC. So these we should be very familiar with, and we'll get to those at the end of this PowerPoint. So we're going to be starting off with our abdominal viscera. So it's kind of just talking about all of the extra, all of the things that are kind of just in the space of our abdomen. Kind of working our way outward in, we have our peritoneal cavity, and this is going to be this protective covering of our abdominal organs in the cavity itself. So it's made up of ligaments and folds that are going to connect the organs to each other and also hold them in place by touching the abdominal walls. So not only is it covering and protecting, but it's giving us a structural support. It's comprised of our lesser and greater omentum, which we'll talk about, our mesenteries, our ligaments, and spaces where fluid can gather. And we'll talk about all of those as we continue on. Now, when we're learning about the peritoneal cavity and we're learning about the omentum and the mesentery, that can all seem very vague, and some of it can kind of overlap with previous information. It's important to kind of go back to this reference photo, this transverse cross section of the abdomen, and be like, okay, so this is what I am looking at in this particular region. What does it mean to be retroperitoneal? What does it mean to be intraperitoneal? And what does that look like in terms of the human body? So we do have some structures that are not going to be encapsulated in our peritoneal cavity, and we call those retroperitoneal structures. Those are going to be more so our kidneys, our great vessels, and some other structures that we'll learn about as we move through the program. So we'll come back to this, or you should come back to that photo as you're studying if you tend to get confused with these first few slides with the viscera. So peritoneum itself, this protective layer, it's a smooth membrane that's going to line the entire abdominal cavity and the organs that are contained within it. Now remember, we just said that not every single organ in the abdomen is going to be located within this peritoneal cavity. This membrane itself is going to have two different layers. It's going to have a parietal layer and it's going to have a visceral layer. One is talking about the inside pocket and one is talking about the outside pocket. So the walls of the cavity, the outer walls that are going to be touching sort of our skeletal structure, sort of our outermost abdominal structures, that's going to be considered our parietal peritoneum. Our visceral peritoneum is going to be the part of this pocket that is touching and surrounding the abdominal organs within this cavity. So if we look at this picture here, this is like a coronal view of an abdomen. We're coming in from the side. Now our parietal peritoneum, we said that's going to be like that outer lining of this balloon. That's going to be that red line that kind of goes all the way around this abdominal cavity, and it kind of outlines the larger area of this cavity. The visceral peritoneum, that's going to be more so this blue layer, right? So that you can see is kind of outlining the liver, coming down and outlining the cross section of some of our vessels, some of our intestines. That's going to be directly in contact with the organ. Now this yellow is everything in between, right? It's the air in the balloon. So that's going to be the peritoneal cavity. So that's the space within that peritoneum, whether it be the parietal or the visceral portion. Next, we have our sacs. So we have a greater sac and a lesser sac. These are kind of talking about, again, general spaces. So we have I'm having a hard time speaking today, guys. I'm going to blame the baby for lack of sleep. We're going to go with that. So we're going to have this specific area, like in the previous slide, we were talking about how we have that yellow space. That's our peritoneal cavity. That's kind of where everything else is going to be situated. We're going to have that general peritoneal cavity that we're going to reference as our greater sac. It's going to be the greater portion of that peritoneal cavity. We also have a smaller portion of that peritoneal cavity, which is going to be formed by this little pocket between the spleen and the backside of the stomach. That's going to be known as our lesser sac. The greater and the lesser sac are still going to be part of the peritoneal cavity. They're regions within the peritoneal cavity, and they're going to communicate with each other through an opening that's going to be right underneath the liver and the duodenum, and that's called our epiploic foramen. We're going to hear the word foramen a lot as we kind of go through and learn more about different organ systems and body structures. It's just a fancy word for an opening, right? So we probably covered that in our medical terminology course, but if you haven't, just know a foramen is talking about an opening. So that's how the two of them are going to communicate with each other. If we look at this picture here, again, that side view, the coronal view, kind of looking at the body sideways, we see that entire orange and blue region is going to make up the whole peritoneal cavity. But if we divide them into these sacs, the orange sac is going to be our greater sac, and then that lesser sac behind the stomach and the spleen region is going to be our lesser sac. Did I just say our orange was our greater sac? Guys, I really am going to blame the baby. So moving on here, we're going to continue talking about our omentum. So we have, again, kind of like the sacs, we have two of them. We have a lesser and a greater. One of them is going to be bigger than the other, obviously. Our greater omentum is what's going to be highlighted in this picture here. It's going to be this little like apron that's a folding kind of layer of peritoneum that hangs from the greater curvature of our stomach and drapes forward and drapes down on top of our intestines. So it's going to act like a skirt for our lower GI tract, and it's going to provide a lot of protection. It doesn't necessarily give us much structural support, but it gives us a lot of protection for those very soft tissue structures like our small intestine and our large intestine. Now, our lesser omentum is going to be made up of similar content, so it's going to be a double layer of that peritoneal tissue that's going to be a little bit more of a structural support instead of a protective support. And it's going to extend from our liver all the way over to the inner curve of our stomach, that lesser curvature of our stomach. And that's going to sort of act like a sling. So imagine like when you dislocate your shoulder and you have to wear that arm sling, it gives you a little bit of support for that shoulder and that arm. So that's what that lesser omentum is going to do. They're both made up of the same contents, but one is going to be more protective, our greater omentum, and one is going to be a little bit more structurally supportive, which would be our lesser omentum. So if we look at our diagram here, our greater omentum is pretty obvious. It's going to be all of this orange structure here, and you can see that it's hanging from this greater curve of our stomach, and it's hanging down, protecting all of our GI tract distal to it. Now, our lesser omentum, we said, is going to basically attach the liver to the stomach. So it's going to come from the bottom part of our liver, and it's going to extend all the way over to that inner curve of our stomach, or the smaller curvature of our stomach, and that will be our lesser omentum. Next, we have our mesentery. So again, kind of giving us a little bit more protection and support here. It's going to be made up of, again, a double layered peritoneal fold, which is going to help to suspend now the small bowel and the colon to the posterior side of our abdomen and our pelvic wall. And it's going to be something that we do not really see on ultrasound. Sometimes we can see omentum on ultrasound. Sometimes we can see mesentery on ultrasound, but we're usually not seeing these structures unless there's something wrong, unless there's something abnormal going on in that peritoneal cavity. Typically, when a patient has some sort of physiologic disease, usually some sort of liver function disease, they develop a condition that's called ascites. It can also be caused by heart disease. Ascites is when you have this abnormal accumulation of fluid that settles in your peritoneal cavity. So it settles in the fluid spaces within this peritoneal region. when you have fluid that is gathering there, it's going to start pushing structures away from each other. So remember we talked about this with the liver. When you have ascites and you have abnormal fluid collections near the liver, it's going to push the liver away from the abdominal wall, and we'll actually be able to see that falciform ligament connecting that anterior surface of the liver all the way back up to the abdominal wall. So ascites is going to do that same thing, but a little bit further down in our abdomen. It's going to make it so that we can actually see the mesentery with the presence of ascites. So not a structure that we are really routinely visualizing. Same thing with the omentums, but when we have fluid accumulating within this cavity, we're going to start to see these things a little bit more abnormally. So, you know, something, again, it's hard to apply anatomy to what we're scanning if we don't see it, and if we only see it in the presence of pathology. But you have to kind of have that information at the back of your mind so that when you do come across that pathology, you know what you're looking at now. You know that you're seeing a structure that you're not used to seeing and why you are now seeing that structure. So here are our peritoneal spaces. These are going to be the regions where we can get a lot of that fluid accumulation. These are regions where we typically will have a lot of our lymph nodes situated, and that's kind of just referencing these general areas. When you are documenting pictures and you're finding pathology, and maybe you're looking at a patient who sees ascites, it's important to use these terms. These terms are going to be very specific and can really help aid with a diagnosis or an ultrasound guided procedure if that's what we're doing to help maybe get rid of that fluid, or maybe biopsy one of those lymph nodes that we see in these areas. So these are going to be a little bit more specific to us, and when we do happen to see that pathology, we're going to reference it in response to these areas. So some of the most common spaces that we see, that we deal with in our world, are going to be the pericolic gutters and the subphrenic spaces. We also use the subhepatic space, but we don't typically use the inframesocolic regions. Bowel is not our friend, right? It has a lot of air contents in it. We can't really see through it. It gives us a lot of shadowing. So anything that is situated in this region, we're going to have a hard time evaluating. We're going to have a really hard time even seeing if there's fluid gathering in those areas, because again, that bowel is still going to be producing gas. We're still not really going to be able to see through it. So we're really looking at those subphrenic spaces, the pericolic gutters, definitely some regions down closer in the pelvis, which we will talk about. But again, we're using these very specifically. So look at the term itself. It's giving you the resources to figure out where that area is, right? Subphrenic. Phrenic is talking about the diaphragm, right? So below the diaphragm. Subphrenic, is it either left or right? Subhepatic, we know hepatic is referencing the liver, so underneath the liver. Pericolic gutters, right? Kind of seems weird, like pericolic, can't really like associate that with anything, but gutters, think of that, it's on the outside of the houses to drain, you know, the rain water. So they're going to be located along the sides of our abdomen, along the sides of that peritoneal cavity. So definitely familiarize yourself with the locations of those particular regions. We are going to come back to talk about the posterior cul-de-sac. That is something that is the region located closer in the pelvis. When we're learning about GYN, we will definitely be referencing that a lot. We tend to see a lot of fluid gather in that area, the posterior cul-de-sac. So it's important for us to know how to image that. But that's a little bit more distal in the abdominal cavity. Moving on to the anterior abdominal wall. Again, this is something that we aren't routinely visualizing, but there are certain exam indications that we have to perform in terms of evaluating this abdominal wall and the musculature and the layers of the abdominal wall. Usually if we're looking for a hernia, that is going to be something that is very tricky for us to find on ultrasound. Once you guys start clinic, you are going to hear a lot of techs complain about having to perform a hernia check, whether it be in the groin or the abdomen. They're just very, very challenging because a lot of these layers look very similar to each other. on ultrasound. But it is something that we are expected to know how to do. And then also we have a lot of post C-section moms. So of course, with the C-section, we're cutting right through all of these abdominal layers. And with that can come complications. They can get a lot of fluid collections that gather in their surgical scar. Their healing could not be as fast as we would anticipate. So we do have to evaluate those patients in their postpartum phase following that surgical procedure. So this is something that, although we may not be doing it every day, we do it a little bit, more so than we would think that we would. So within the anterior abdominal wall specifically, we're not really ever looking at the posterior abdominal wall because that's really kind of just going to be the spine, right? So the anterior abdominal wall, looking at our layers going from superficial to deep, so going from belly button all the way down to basically that posterior abdominal wall with our spine. We're going to have our skin. Underneath our skin, we're going to have 2 layers of fascia. We're going to have first our Camper's fascia, which is going to be more of a fatty layer. Underneath that, we're going to have Scarpus fascia, which is going to be a fibrous layer. Underneath our 2 double-layered fascia, we're going to have our muscle layers. These don't necessarily overlap each other directly, depending on where in that anterior abdominal wall we're looking, but we do have to know that our muscle layers include the rectus abdominis, external and internal oblique muscles, and the transverse abdominal muscle. And then once we go through our muscle layers, we have another layer of fascia, that's our fascia transversalis, and then distal to that, or more posterior to that, we are going to be hitting our peritoneal cavity. So that's when we're going to see that peritoneum membrane, and anything underneath that will be considered those intraperitoneal organs. So if we look at this picture here, this is showing kind of a nice little progression of what those layers look like. So our first layer is going to be our skin, very thin. We're going to have 2 layers of our fascia following that. So we're going to have our fatty Camper's fascia, and then a very, very thin layer of that Scarpus fascia, that fibrous kind of layer before our muscle. And then again, depending on where we are in the abdomen, we're going to see first our external oblique, then our internal oblique, then our transverse abdominis. If we're kind of out more on the sides, if we're more midline, we're going to see that rectus abdominis a little bit in between these muscle layers here. And then we're going to have, once we're past those muscle layers, we're going to have our transverse fascia, and then anything distal to that or posterior to that is going to be the peritoneal lining. So here is our rectus abdominis. So this is kind of what I was referencing when I was saying, like, depending on where in the anterior abdominal wall we're looking, we're not going to see every single muscle layer, and we're not going to see them directly layering on top of each other. So our rectus abdominis, this is going to run longitudinally, where all of our other abdominal muscles either run obliquely or transversely. So this is going to be really that supporting core muscle that's going to run from our xiphoid process of our sternum all the way down to our pubic bone. So it's really going to extend the entire length of our abdomen and our pelvis and even up into our chest. It's going to sit midline. It is protected by a sheath, and then the sheath is actually going to join together from both sides to form what is known as the linea alba. If you have ever seen a bodybuilder with a 6-pack and that very, very prominent crease that goes right down the middle of their abdomen, that crease is going to be the linea alba. That's where the 2 sides of this rectus abdominis sheath are joining together. So where we have that joining is going to be that linea alba. Now that sheath is also going to attach to the musculature surrounding it on the sides to the rest of the abdominal cavity. So pretty important muscle here. Usually if we're looking at the anterior abdominal wall most anteriorly, like right on top of a patient's belly button, we're going to be seeing that rectus abdominis first, followed more posteriorly by that transverse abdominis and some of those obliques as we move more out to the sides. What does this look like on ultrasound? Now, again, depending on where we're looking within that abdomen, we're either going to see rectus abdominis right along that midline, or if we're out to the sides a little bit, we're going to see the oblique muscles. Each layer is going to or should display a slightly different echogenicity. But when we get into those muscle layers, all of those muscles typically look the same in terms of echogenicity. So when we're looking from superior to deep, our fatty layers, right, are going to be a little bit more hypoechoic, which is strange because you probably think, okay, well, fatty tissues, softer, less dense, less attenuation, they should be brighter, right? But think about if you're trying to compare that to traveling through ligaments or traveling through muscle tendons. Those are going to be super, super, super dense, right? Very fibrous, very dense. They're going to be a little bit higher attenuation, so they're going to be more hyperechoic, and they might even produce shadowing. Okay, so we're always doing it in comparison to the nearby structures. So although we would think a fatty layer is going to be hyperechoic because it's soft and squishy, in comparison to the nearby muscle layers of the abdominal wall, it's going to be hypoechoic because those muscle layers are much more dense than those fatty layers, right? They're going to attenuate more. They're going to be more hypoechoic because they're denser, they're firmer, right? So it's going to be a little bit different as we learn about echogenicity of structures throughout the program. The way we learn one thing is going to not apply to the next system or the next organ or the next structure. So you have to think of it as very isolated little pockets, right? And everything is comparison of what is nearby, what is adjacent. So here, if we're looking at our ultrasound picture, this is not my favorite picture in the world because it doesn't really do a good job of showing us the skin layer. It's not really great at showing us the more superficial fascia here, but it's just showing you how these layers kind of stack upon each other and how they have different displays of echogenicity as we go. So with this, we would want to be able to see a skin layer. We would want to be able to see our 2 layers of fascia. So here is our fatty layer here, our Camper's fascia. Underneath it, we're going to have our Scarpa's fascia. This one's going to be much more bright, right? Because it's fibrous and it's dense. It's going to be hyperechoic. And then underneath that, we have our muscle layer. So this is telling us that we are looking at our external oblique muscle, then our internal oblique muscle, and then our transverse abdominis muscle. So this is going to tell us that we're not directly midline because we're not seeing rectus abdominis. We're out to the side, and that's why we're getting our obliques here. So that's the border of our external oblique. That's the border of our internal oblique. That is the border of our transverse abdominis. And everything underneath here is going to be our peritoneal cavity. Moving into our vasculature. So we are a little bit familiar with our aorta, so we should have, some context clues with this information, but we are going to start actively scanning this in lab. We're going to be starting to document it because the aorta can be an isolated exam when you start clinical. It is part of a routine abdominal exam, but it can be its own very in-depth exam that we are responsible for performing. So the aorta itself is going to be the main vessel that is going to be responsible for carrying blood from our heart to the rest of the body. Everywhere else in the body, all of that arterial blood supply from the heart is going to travel through some portion of this aorta. The abdominal aorta is what we look at the most. That's not to say that that's the only section or segment of the aorta. There's an ascending portion of the aorta, there's a thoracic portion of the aorta, then there's the abdominal aorta. That is sort of what we're looking at, the meat and potatoes of abdominal artery in terms of our profession. If we were to be in an echo program, we would be looking a lot more at the ascending and the thoracic aorta because echo looks at the heart and looks at the chest, but we don't. So we are going to be focusing on the abdominal portion. So this is the portion that is going to be traveling down the body from the heart. Once it kind of goes up, so it goes from the heart up into the ascending aorta, it loops down through our aortic arch into our thoracic cavity, so it's going to be our thoracic aorta. Once it passes beyond our diaphragm, it is now in our abdominal cavity, and it's going to be considered the abdominal aorta. It's going to travel all the way down our abdomen, and once it gets into our pelvis, it's going to split, or what we call bifurcate. It's going to split into 2 different arteries, and each of those arteries are going to go down to the respective leg. So we'll talk about that a little bit more when we get into our branches. The aorta itself, so like most arteries, they're made up of three particular layers. We have an inner layer, a middle layer, and an outer layer. The inner layer is going to be our tunica intima, middle one is media, and our outer one is adventitia. In order to kind of help you remember what layer is located where, if you think intima, think intimal, right? Hugging and snuggling, and you're in close contact with somebody. This is the layer that is going to be in close contact with the blood as it's traveling through. The media, think right in the middle, medium, middle. Adventitia, think you're adventurous, you're living life out on the edge. You are the outer layer of that arterial wall. Our tunica media, usually the middle layer of our arteries, are going to be made up of a lot of contractile muscle fibers. So that's going to help continuate the pulsation from the heart. So it's going to help kind of propel a lot of our blood supply to the more distal sites. So we have that contraction of that middle layer of our arterial wall. The position of the aorta is very tricky to learn, and as we learned last week, it's going to kind of be in reference to the majority of our intraperitoneal structures. We have to learn about the aorta in relationship to the liver, the gallbladder, the pancreas, the spleen, the intestines. Then we have to worry about it going down into the legs. So the aorta, although it is a simple vessel, right? It's just a tube. It's very, very important. And there's a lot of branches that come off it in order to supply all of those structures that are located near it. So the aorta is going to lie behind a lot of these structures. It's going to be posterior to the left lobe, excuse me, posterior to the left lobe of the liver. It's going to be posterior to the body or the middle portion of the pancreas. It's going to be behind the pylorus of the stomach. So kind of that curvature of our stomach before it enters into the duodenum of our intestine. And it's going to be behind the splenic vein, which we know is going to come from our spleen and travel through behind our pancreas and head up towards our liver. So it's going to be behind all of that. So now we're going to be talking about our branches. This is going to be something that you have to figure out a way to remember. Whether it's making up an acronym, making up some sort of rhyme, whatever it is to help you remember these branches and what they supply, just, do what works for you. The first branch, there are pretty much four major branches or four major things that come off the aorta within the abdominal portion. The first one is going to be our celiac axis. You'll also hear it referred to as the celiac trunk. They both mean the same thing. Celiac is not really one vessel. The celiac is going to have multiple branches that come off that axis to go off and supply respective organs. Our next branch that comes off slightly distally to the celiac is going to be our SMA, our superior mesenteric artery. Coming off below that, further down distally in the body, are going to be our renal arteries, a left one and a right one. And then more distal to that, right before our aorta is going to bifurcate, we're going to see our inferior mesenteric artery come off the aorta. Then when we have that bifurcation happen, we know the aorta is going to split into two. It's going to now become two iliac arteries, and those are each going to go to one of the legs. And go down to supply those legs respectively. Now our celiac axis, like we said, is going to be kind of this region where a bunch of different sub-branches come off it. Typically these three: left gastric artery, common hepatic artery, and splenic artery. Now we've already talked about the common hepatic artery, where it comes from, where it goes. Same thing with the splenic artery, but we didn't really talk about the gastric artery that much. So with that, if we look at this diagram here, this is going to be our celiac axis. Our hepatic artery is going to branch off and head to the right because it's going to the patient's liver. And then the splenic artery and the left gastric artery, the gastric artery is going to supply the stomach, the splenic artery is going to supply the spleen. So these are going to head off to the left side, right? Because the spleen and the stomach are located on the left side of the body. So they are going to go off to the left side, and then that's where they're going to split. One is going to head to the spleen, and one is going to head up to the stomach. Now, coming off the aorta more distally, we're going to see our SMA, our superior mesenteric artery. That's going to supply the duodenum, small intestine, and transverse colon. Everything in that GI tract that's located a little bit higher up, a little bit more in that proximal GI tract. Now, coming off even more distally from our SMA is going to be our left and right renal arteries. Typically, the left renal artery is going to come off the aorta a little bit higher than the right. And that's because on the right side, we have the liver that's kind of pushing everything down, right? Our liver is huge. It takes up a lot of that right upper quadrant. So it's pushing everything down. We're going to learn that our right kidney is located a little bit lower than our left kidney because there's not anything fighting it on the left side. So that's why our left renal artery is going to come off a little bit higher. And then more distally to those renal arteries coming off, we're going to have our IMA coming off. That's going to supply the more distal portion of our GI tract. So the large intestine, the cecum, the rectum, all of those structures that are located a little bit further down. We do not routinely visualize the IMA on ultrasound. Very, very small. It's going to be kind of situated in the region of those intestinal structures. So they're kind of blocked by a lot of that gas. We're not really able to look at it that well. And if we see it, it sort of has to be a perfect situation for us to visualize it. The patient has to have, no bowel gas, be super, super thin, and it's just, it's virtually impossible for us to evaluate the IMA. And then we see once the IMA comes off, we have our bifurcation into our right iliac artery and our left iliac artery. So how do we evaluate the aorta on ultrasound? What does it look like, and what is the role of our job? So on ultrasound, the appearance should be as anechoic as possible. We want to be able to see that fluid-filled, that blood-filled lumen. The lumen is talking about the inner pathway of a vessel or of a duct. The walls of the aorta are going to be very echogenic, and they should be a little bit thicker than the walls of a vein. We are going to see the aorta in sagittal with nice long positioning going all the way down the body. It's going to be pulsatile, right? Because it's responding to the cardiac contractions. It's sending out blood flow through the artery. So we're going to see that very subtle pulsation. It's also going to be a tubular structure, right? We're going to be able to see how it's running up and down the body like a tube. Located anterior and slightly to the left of the spine, particularly if we're looking in transverse, we're going to see it towards the left of the spine. And remember, that's going to be on the right side of our screen. Anatomically, it's on the left of the spine. And then you can also use your left lobe of the liver as a landmark. So when we're either in sag or transverse left lobe, we know that we're going to see our great vessels posterior to that left lobe. The technical applications, we want to make sure that our patient is NPO for at least 6 to 8 hours. Like we said, it is routine to visualize the aorta as part of an abdominal exam. So they're going to be NPO for that anyway, but we can also just do isolated, in-depth, detailed aorta exams on their own. So we would also have them prep for that by not eating anything for 8 hours to minimize that bowel gas. We're going to be using our curved probe. We're going to have our patients start in supine, but we also can have them decube to help kind of move that bowel gas out of the way and maybe evaluate the aorta from a coronal approach. What is our protocol? So sagittally, we're going to be looking at the prox, mid, and distal portions, so proximal, middle, and distal portions. The diameter of the proximal aorta is going to be wider than it is at the distal portion. Sometimes we can see in the distal portion that it sort of starts to bulge in diameter. You'll see it kind of wide up at the proximal portion, and then it slowly kind of gets a little bit more narrow as we head to mid, and then it kind of gets a little bit more narrow as we get to distal, and then right above where it splits or it bifurcates, it kind of can do this little increase in diameter. That can be tricky because that is a normal thing. It's normal to have an increase in the diameter right before the bifurcation, but you want to make sure that it is not an aneurysm, which we will talk about in like 2 or 3 slides. So just hold on with the term aneurysm. We also want to be able to evaluate in sagittal the bifurcation. So we're looking at that right iliac artery and that left iliac artery. We annotate these as RCIA or LCIA because it stands for right common iliac artery or left common iliac artery. Once we learn about a little bit more into the vascular world and the vascular evaluation of our lower extremities, we'll learn about where those terms come from. So just be familiar with either RCIA, LCIA, what that stands for. It just means for right now the same thing as the right and left iliac arteries. Once we evaluate it in sagittal, we then go back and evaluate it in transverse. So we're going back up to that proximal portion, mid portion, distal portion. We're evaluating the bifurcation, and we're looking at that with color as well. Throughout all of those pictures, we are going to be Dopplering them to make sure that that arterial waveform looks appropriate, but that will come with the lab component of things. So just know that we have to do a very detailed evaluation in sag and transverse for the aorta itself. When we're combining it with an abdominal exam, we usually would only do 1 or 2 sag pictures, even if we evaluated the whole thing. Of course, if there's ever pathology in that structure or any segment of the aorta, and even if it's not a dedicated aorta exam, you're still going to document that for your radiologist. So here I have, I've kind of lined up the 3 sagittal views, the proximate and distal. When we are scanning the aorta, and you'll see it once we have lab, you have to change the angulation of your transducer when you're in sagittal. This is really where you're going to hear me say heel toe quite a bit. So make sure you refresh your memory on what that means. It means you are rocking it like a sailboat, right? So you're going front to back, and front to back, and front to back, okay? So we're tilting forward, and then we're tilting backwards. When we're looking at the proximal aorta, we want to be tilting upward, up into that patient's chest. That's going to give us a slight angulation of that aorta going up our screen like this. That's what we want. We want to have it kind of going up on an angle from left to right. Our mid portion is going to be kind of straight across the screen, because then when we're in the mid portion of the belly, we're putting the transducer directly perpendicular to that anatomy. So we're going to see it a little bit more straight across. Then when we're doing distal, we're going to heel toe downward. We're going to follow that pathway that that aorta is taking down towards those patients' legs. And that's where we're going to see it go across our screen downward from left to right. So proximal, we see it going up our screen from left to right. Mid, we have it kind of going straight across just because of the perpendicular nature of the anatomy and the transducer. And then in distal, we're angling down so that it travels downward across our screen from left to right. And then this picture here is really nice to show that bifurcation. Here in transverse, we have our pictures again, starting from proximal going all the way to distal and bifurcation. So proximal, we said the first branch off the aorta is going to be our celiac axis, and that's going to be all of these little structures right here. So that the red arrow is going to be the celiac axis, the green arrow is going to be our hepatic, and that left arrow is going to be the branch that the left gastric and the splenic artery are coming off of. Moving downward, a little bit more distally in a transverse fashion, we're going to see this SMA coming off. Moving even further down, we're going to see the renal arteries coming off sort of together. But in this picture, you can see that the left one is a little bit more obvious here than the right one is. And that's because in order for us to get that right one to pop in, we probably need to slide our transducer down just another millimeter. Because again, remember, it comes off a little bit more distally. And then more distal to that, we're not going to be able to see the IMA coming off. So we just want to follow that until we see the bifurcation. So until we see that aorta split into 2, we put color on it to confirm that those are arteries, and then we call it a day. I am going to go back for 1 second because I wanted to show you in this proximal sag slide. It's a really great example of the celiac axis relationship to the SMA. So remember, this is the patient's head, and these are their feet. We said the first branch of the abdominal portion of the aorta is going to be our celiac axis. And then look how close the SMA comes off just distally to it, just closer to the patient's feet, right? So very easy to be confused for one or the other. especially in a patient that has them this close together. So I'm sure we'll see a few of these when we start scanning in lab, and we'll be able to identify the difference between the two. And in transverse, it's pretty straightforward because you're not going to see branching coming off the SMA. You're only going to see branching coming off that celiac axis. So what are we looking for? Okay, so the main part of doing evaluation of the aorta is to rule out an aneurysm. An aneurysm is an abnormal dilation of that arterial lumen to the point where it starts to weaken the walls. Once the walls are weakened, we run the risk of rupture. And we clearly do not want the greatest artery in our body to rupture because we will bleed out very quickly. We'll have a lot of internal bleeding very drastically, very rapidly. So we want to make sure that we're catching those aneurysms before that rupture happens. When we're looking to see if there is an aneurysm, we're looking for any sort of dilation in the diameter of that vessel. So we don't ever want to see a diameter that is above a certain size. There's completely different criteria out in the radiology world. Some places will tell you that the cutoff in terms of the greatest AP diameter is going to be 3 centimeters. Other places will tell you 2.5. Other places will tell you 3.5. It all matters depending on the facility and depending on the radiologist. Either way, if you see any area that looks significantly wider than a different segment of the aorta, document it. If you see any area that's 2.5 or wider, document it. Now, this criteria here from the textbook is saying that a woman's proximal AP diameter can only be 2.3 centimeters. That's a little bit of a stretch. So if you were to document a female patient's aorta with a diameter of 2.3 or 2.4, they're not going to consider that an aneurysm. That's kind of just the ballpark. Usually once we start getting closer to 3, that's when people start paying a little bit more attention. That's when a radiologist starts changing their impression a little bit of your pictures. So again, highly subjective depending on where you're working, where you're scanning, and what the physician believes in terms of literature and research. But just know that anything in that 3 centimeter ballpark, we really need to be advocating for the patient. There are certain aneurysms that can extend all the way up to 6-7 centimeters, and it's absolutely wild to see. So they get very, very, very big. Some of them only rupture when they're 3.2 or 3.3, so it really doesn't matter. We're also looking to see if there's a thrombus formation within that aorta. So that's going to be when we have an abnormal accumulation of blood cells that's going to start to coagulate in that vessel. It's going to lead to potentially either a life-threatening blockage, meaning that the blood flow can't get through that accumulation, or that accumulation with response from the pressure of the arterial system can break off and travel, and that means to embolize. Now, if we are in the abdominal aorta, the only pathway is down. So if it were to break off and travel, it's only going to embolize and end up at the furthest part, which would be our toes. A little bit more concerning when we see a thrombus in the carotid artery or in the heart itself. If we were to see a thrombus in the carotid artery, which is the artery that comes off our ascending aorta and travels up into our head, and the distalmost part of the carotid embolism would be your brain. So you could have a stroke from that. So very serious, and either way definitely needs medical attention regardless of where it's located. We're also looking for calcifications. A lot of dietary problems, especially within our society. We have a lot of accumulation of plaque within our cardiovascular system. This calcification, it not only runs the risk of breaking off and traveling as well, just like that thrombus does, and embolizing in the same fashion of that, but it can also really significantly weaken those arterial walls. So we get poor circulation, we get potential ruptures of arteries, we get potential splits of arteries in the arterial wall. So although it's a little less acutely important than an aneurysm or a thrombus, it's still very important to monitor. Typically, it's going to result from poor dietary habits, like we said. As we get older, our fatty cells tend to increase, so old age from disease. Smokers tend to develop a lot more calcification in our cardiovascular system, so something, again, to keep our eye out for. It's going to appear as very hyperechoic kind of little blobs in the arteries, so we're not going to see that nice, beautiful anechoic lumen, and we'll get a lot of shadowing from those calcifications as well. And then we also want to be emergently aware of a dissection. So this is something that if you work in a trauma hospital and they call you into the ER bay following a car accident, it is most likely to evaluate for a dissection. So this is when the inner layer of those walls tear, and it's not necessarily a rupture where it just ruptures and it rips outward. It's a tear within the walls. So the walls start to separate from each other. And that's what we call that dissect, that dissection, is they're starting to split away from each other. So we're getting this accumulation of that arterial blood that's kind of pooling and pooling and pooling and pooling in the wall. And then eventually it's going to get to the point where it rips completely and it ruptures completely. And then we're back to the problem of having a ruptured aneurysm. So all very important things that really make our job so stressful, but also very important. You know, we have to be able to identify these things and to document them properly and know when somebody needs immediate medical attention. If we were to look, you know, maybe say we were doing a routine aorta on a guy who was 65 and maybe he was a smoker, but you know, his doctor just sent him in for this just to check and just to make sure, because we get those patients all the time. And then we're scanning and we see a dissection and we say, oh, that's cool, you know, I learned about that, right? But you also should know that you learned that that patient needs to go to an OR immediately. So would we let that patient go home? No. If our patient comes in with, oh, you know, I've had a little bit of a bellyache, and sometimes when I touch my belly button, I can feel it pulsing, and you put the probe down and you see a 7-centimeter aneurysm, we're not going to let that patient go home. So these are all things that you have to have and develop the critical thinking skills to take it to the next step, right? Call your physician immediately. Have that physician communicate on behalf of the patient so that they get the immediate medical attention that they need. Calcification, little less, you know, acute process, but everything else on here, very important. Moving into our IVC, so the venous great vessel. The IVC is going to be that main vessel that's going to carry the blood from our extremities and our abdomen and pelvis back to the heart. So the aorta brings it and the IVC takes it all back. When we're looking at the aorta, the origin of the aorta is the heart, right? And the end point of the aorta is your fingers and your toes. With the venous system, the end point is the heart, and the origin point is your fingers and your toes. Okay, so that's going to be something that we kind of have to think of backwards in a sense. So the veins start distally in our body, and then they end proximally at our heart. So this is going to be, the IVC is going to be the union of those leg veins joining together, right? Those common iliac veins. We just learned about the iliac arteries. Going to be a paired vein that goes with it. So our left and our right iliac veins are going to come up from the legs and they're going to join together in the pelvis to form one, and that one is going to be the IVC. Now that IVC is going to travel vertically upwards through our abdomen. It's going to be behind the peritoneal cavity, right? So go back to that very first picture with our cross-axis view of the peritoneal cavity. It's going to travel behind it. It's going to travel posterior to the liver and on the right side of the aorta, and it's going to enter back into the atrium of the heart. Okay, so it's a little bit backwards. It's following the opposite pathway of our aorta. So on the left-hand side, we see left and right iliac veins joined together in the pelvis to form the IVC. Like the aorta, we're going to have branches, but these branches are draining into the IVC, right? Traveling up the heart, Oh, look, we had our little hepatics that are draining in right there. Going to pass through the diaphragm, up, 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 and back into the heart to be processed again and then to be sent out of the heart into that aorta. So here are the branches of our IVC. We learned about our superior mesenteric vein, right, in terms of the supply to our liver, portal splenic confluence, right, the splenic vein joins with the SMV from the intestines, form the portal vein. Really all you need to know in relationship of these branches to the IVC is really just that SMV. Draining the intestines, traveling up, forming the portal splenic confluence, entering into the liver, and then it's going to filter out of the liver through those hepatic veins back into the IVC. So the venous drainage of the body is a little bit more complex than the arterial supply is. So try to not think too much into it. Now we're kind of just adding the IVC into what we were kind of talking about in previous modules. So evaluation of the IVC on ultrasound. So kind of similar to the aorta. It's the same prep, right? Still part of an abdominal exam. We don't really do an isolated IVC exam. There's really not much of a need to do it, but it is part of a routine abdominal exam. Still curved probe, still NPO, still supine, turn if necessary. But the appearance of the IVC is going to be a little bit different, and you have to be aware of what these differences between the IVC and the aorta are. They're both going to be anechoic. They're blood-filled structures. Unlike the aorta, the walls of the IVC are going to be very, very thin, and they're going to be collapsible. So this means that they're going to respond to pressure changes. Now, our arterial system, very, very high pressure system. That's why it doesn't really change its diameter at all, right? All it does is it pulses a little bit bigger to respond to that heartbeat. It doesn't change diameter. With the IVC, because it's a low pressure system, it can respond very easily to any pressure changes. So if our patient is breathing really quickly, or if they're exercising, or if they're standing up, all of those pressures on that vein can change how it appears. So phasicity is talking about the different phases that that vein can go through. So we're going to see diameter changes depending on the patient's breathing. That's termed respiratory phasicity. And then we also can see it in terms of pressure changes. So sometimes when we have our patient Valsalva, sometimes when we have our patient blow their belly out, that's going to change that internal pressure of the abdominal cavity and therefore have a direct effect on the diameter change of that IVC. We also want to make sure that we are looking and evaluating it with color Doppler evaluation. When we are Dopplering an artery versus a vein, we're either going to have continuous flow or pulsatile flow. And we'll talk about that in our next, I think I have a slide in a few, where we'll talk about what that looks like. The technical application is still going to be the same as the aorta, like we said, NPO, supine, curved probe, routinely part of an abdominal exam. What is our protocol for the IVC? Nothing crazy. It's really not anything that's super in-depth. We're really just looking at it sagittally in the proximal region. We're going to put color on just to prove that it's the IVC. We're also looking for a thrombus. We don't typically get venous aneurysms, but we do more likely get venous thrombus than we do arterial thrombus. So something to remember as well. The scary part of having a thrombus in the IVC, so we just learned about what happens if we have a thrombus in the aorta. The furthest part it can travel off and break off to is our toes, but think about where the furthest part of an IVC thrombus can go. What is the end point of the IVC? It's the heart. So it's a direct heart attack from a thrombus in the venous system, particularly in the IVC, because it's so closely positioned to that atrium of the heart, and that's the end point. So we definitely don't want to see any thrombus gathering in that IVC. We're typically using our IVC as a landmark. What am I getting at there? Oh, we're typically using our IVC. So in addition to that sagittal picture in the proximal region with color Doppler evaluation, we're typically using our IVC as a landmark in our other pictures. So when we're doing that sag left lobe, we know that we're using our IVC to help us. When we're looking at our pancreas, we know that it's going to be nearby. When we're looking at our aorta, taking our more in-depth aorta pictures, we know that we don't want to be confused with our IVC because that's also going to be right near it. Sorry, that's what I was getting at, guys. So here we have some nice pictures of what you would be obtaining while you're doing an abdominal exam. Again, we're kind of just sticking in that proximal region because that proximal region is most important if there were to be anything wrong or going on in that IVC. So this picture here, top left corner, this is something that we see very routinely when we're doing that sag left lobe of the liver. And we know that our IVC is going to be directly posterior to it. It's going to be that border between the left and the right lobe. When we kind of sweep a little bit more towards the patient's right side, so heading a little bit closer to that right lobe of the liver, we're going to see that hepatic starting to drain into our IVC. So here's our IVC traveling this way, because again, this is the patient's head and therefore the patient's heart. So our IVC is going to go right into that heart. That left hepatic is going to drain right into that IVC. Here is our color Doppler evaluation. So we put color on showing blue flow, so blue below the baseline. We're going to assume from this picture because it doesn't have a color map. So it's traveling away from our transducer. It's traveling in this direction, so that makes sense, right? Because here's our transducer. So it's traveling away from us. If it was traveling towards us, it would be going like this. So it's blue. And then this is what we're talking about in terms of Doppler waveform. So it's either pulsatile or continuous. This is going to be continuous waves. This is not a pretty waveform, right? Veins don't really give us pretty waves. Arteries give us pretty waves. They're pulsatile. They go like this, right? Just imagine that these are all uniform, but they're routine. They have a pattern. They look the same. Our veins don't do that because it's responding to very subtle pressure changes. So every time the patient is breathing or moving or talking, we're going to see that flow kind of change a little bit. So that's why this waveform here does not look like a perfect, pretty pattern, right? It's not pulsatile. It's not this rhythmic thing that we're seeing. It's flow also below the baseline, right? Just like our color. That blue is going to be below the baseline. So this waveform is telling us that this flow is traveling away from us, whereas this artery here is traveling towards us because that would be representing red flow above the baseline towards the transducer. Picture on the bottom right-hand side, this is everyone's worst nightmare. That's a thrombus in the IVC. So this is a little bit more in that mid portion of the IVC because we know we're a little bit further down in the body from this gallbladder being right here. We're also kind of cutting off a little bit of that left lobe. We're not really seeing much of that superior region. So we're a little bit lower than we are in, say, this picture, right? Or if that picture had this clot, it'd probably be hanging out like somewhere over here. So that is our worst nightmare. We never want to see that. Very straightforward picture there. This whole thing, this whole echogenic circle has a very high likelihood to travel right into that patient's heart and cause them to have a heart attack. So a lot of new information on this PowerPoint, especially with the abdominal viscera, the abdominal wall, those different segments and sections and structures, and all of that is pretty new, and it's a little bit harder because we aren't necessarily looking at it on a routine basis. But I am going to start to expect you guys to incorporate a little bit more of your aorta and your IVC knowledge when we're in lab. So make sure you have a good understanding of that. And if we need to, go over specific questions in lab, we certainly can. Please don't hesitate to email me or set up a time to come and meet with me if you have any questions about the lecture.